give a brief presentation on intraoperative things to prevent hip dislocations. So, Sahil.
Yes, sir. Yeah, is it visible?
Yes, Sahil, yeah.
Okay. Good evening, everyone, and thank you for the opportunity, Kulkarni sir and Pachore sir. So today I'll be talking on bearing surfaces in total hip replacement. And let us consider what all tribology and what all factors go into selection of the bearing surface. So I have no relevant disclosures. So the outline or the objective of my talk will be that I'll be starting with Chanley's low friction arthroplasty. Then I'll speak about metal on metal, polyethylene, followed by ceramics, and then the newer developments of Auxinium and dual mobility. And then just a brief about the future trends or the possibilities that could be there in the future with regards to bearing surfaces for total hips. So the way I'll be going about this presentation is, some of you all might have read about this topic earlier, and some of you might have already even heard a few lectures on this. And it's actually quite a theoretical topic. So I have a slightly different approach to this, in the sense that I'll be talking more about the practical aspects that could be relevant and will be helpful to you all in a day-to-day practice. So at least you all can get some good practical messages and take-home messages. And I won't be going too much into the theory of this topic, because all of you all can probably read that and understand it as well. So let us see what is the meaning of the word tribology. Tribology is the science that studies friction, lubrication, and wear between two surfaces which are in close contact and move on one another. And this is actually derived from the Greek word which means rubbing. So as you can imagine, that the femoral head and the acetabular liner are both rubbing against each other. And this is what we study in tribology, that is friction, lubrication, and wear of the bearing surfaces. So what is wear? When we talk about wear is basically the surface damage due to friction between two moving surfaces. Because of this friction, there is a progressive loss of material of the bearing surface, that is of the head or the liner, and this leads to particulate debris, which are known as wear debris. So with regards to bearing surfaces, each orthopedic surgeon or arthroplasty surgeon should remember one thing, that every arthroplasty surgery will eventually fail and require revision. And that is why you must have good knowledge about your bearing surfaces. We have more and more younger patients who are undergoing surgery, and we know that the rates of complications are higher in these patients, and longevity is again the main goal here. So a few decades ago, we would wonder how many years will a total hip last? But now the question is changing. And with all the advances in tribology, we're wondering how many decades will a total hip replacement last? So why is this controversy in selection, first of all? Why do we wonder which bearing surface to choose? Because like I mentioned, the first thing is young patients. Secondly, there are very few studies on this topic because of a lack of long-term follow-up. So as you can imagine that when there is any new bearing surface which comes out, it has to be in practice for at least 20 to 30 years for the data to come out. And only then will we realize retrospectively how these bearing surfaces are behaving. So right now, bearing surface selection is a mix of experience-based and evidence-based. So why does a total hip arthroplasty eventually fail? It's because of mainly two factors. One is the failure of fixation, that is between the shell and the host bone, or between the stem and the host femoral bone, which causes aseptic loosening. And the other one is eventual wear of the bearing surfaces. So now, beginning with the major classification for bearing surfaces, there are two major classes of bearing surfaces. One is hard on hard bearings, and the other is hard on soft bearings. So when we say hard bearings, we are mainly referring to metal alloys, that is cobalt chrome alloys, or ceramics. Whereas when we say soft bearing, we imply polyethylene, whether it was the conventional ultra high molecular weight polyethylene or the newer advanced highly cross-linked polyethylene. So when we say hard on hard, the first word or the first term denotes the femoral head, and the second term denotes the acetabular liner. So an example of hard on hard bearing is metal on metal or ceramic on ceramic, and some cases of ceramic on metal. Whereas the hard on soft bearings, examples of those are metal on polyethylene or ceramic on polyethylene. So when you say metal on poly, metal implies the femoral head and polyethylene is the acetabular liner, and the similar situation or the nomenclature for the ceramic on poly. So the first advancement that happened in total hip arthroplasty was Chanley's low frictional torque arthroplasty, which was in 1958. And the bearing surface chosen by Sir John Chanley was metal on polyethylene. And he is regarded as the father of modern total hip arthroplasty. And his concepts remain relatively unchallenged even today. So what was his concept all about? His hypothesis was that high forces, when they are exerted on a hip implant, will contribute to loosening over time. And the basis of this was that the largest possible difference between the radius of the femoral head and that of the outer aspect of the acetabular component. So if you see in the image on the left, that is figure A, it is a small femoral head with a relatively large acetabular liner. In comparison, the image on the right side has a larger femoral head with a smaller acetabular liner. And the aim is to protect the bone cement interface by making movement take place at the smaller radius, that is the articulation between the femoral head and the liner, as compared to the toggle force which would act on the liner and the shell. So what are the differences in Chanley's hip replacement compared to modern day total hip replacement? Chanley mainly used a lateral approach with a 22.225 millimeter head. Now we have various approaches and head sizes are 28, 32, 36. His bearing surface was metal on PTFE, Teflon, whereas nowadays we're using more of ceramic on polyethylene and ceramic on ceramic. He cemented the femur and the acetabulum, whereas now we have various types of fixation. In addition, he lateralized the greater trochanter with an osteotomy and wired it, and medialized the acetabulum, which is not done in today's day and age. So then came the next advancement of metal on metal. This was started mainly by Philip Wiles and McKee, who advanced the metal on metal bearings. And the potential benefit, as you can see from these X-rays, was that it allowed you to use a large diameter femoral head. The advantage of this large diameter femoral head was that it optimized the range of motion and the hip stability. However, their hypothesis was that the metal debris, because of where naturally the metal debris that would be expected would be ionic, and hence they would be easily cleared by the kidneys and hardly cause any minimal local tissue reaction to the wear debris. However, unfortunately, this was not true, and this led to the term adverse reaction to metal debris, which comprises various terms like metallosis, pseudotumor, and alveolar lesions. So what was this pseudotumor all about? It was mainly an aseptic mass in the periprosthetic tissues, and it could either be solid or cystic. Why was it called pseudotumor? Because it mimicked the local effects of neoplasia or infection, but it was not an infection, nor was it a tumor. And these patients presented with symptoms of pain, reduced mobility, implant loosening, and failure. ALVAL, on the other hand, stands for aseptic lymphocyte dominant vasculitis associated lesion. And this is mainly a histological diagnosis. The cells would be exposed to the cobalt and chromium ions, and this would cause a lymphocyte infiltration. And this is basically a delayed type 4 hypersensitivity reaction. So as you can see in the image here, it is a predominance of lymphocytes, which was discovered on the histological examination. Another problem with metal heads, which is irrelevant even today, is that of trininosis. So what is trininosis? Trininosis is the wear at the junction of the femoral head and the neck. So where the femoral head, that is the metal head, would articulate with the taper of the femoral stem, The wear at this junction, as you can see in the red arrows in the image, is called as Trininosis. And this is mainly because of two reasons that we call as fretting and corrosion. So fretting is basically the micro movement which happens at this junction, whereas corrosion is more of an electrochemical reaction. Again, I won't go too much into the details of fretting and corrosion, but you must remember that Trininosis is a potential problem of metal heads. Again, there were systemic side effects like cardiotoxicity, neuropathy, ocular and thyroid toxicity, nephrotoxicity, and even malignancy, which raised further concerns and eventually led to a recall of this implant of metal on metal. So why is this important? If it has been the implant has already been called back, why are we spending so much time to read and understand about metal on metal? The most important thing here is the practical knowledge or the practical aspect of this bearing surface is that you should know how to work up a patient who has had a metal on metal. For example, a patient may have had it a few years ago and presents to you in the OPD with this kind of an X-ray. And nowadays, even the patients are aware of the recall of this implant. So they may ask you, Doctor, am I at any risk of any toxicity? What investigations should I do? And that is why you should have a good idea about how to work up patients for metal on metal surveillance. So it is a combination of history and physical examination, lab investigations, and radiological investigations. So in history and physical examination, you must differentiate, first of all, whether the patient is symptomatic or asymptomatic. Analyze the gait of the patient. Is it a Trendelenburg gait or an antalgic gait? Are there any early signs of abductor weakness? There might be a pseudotumor which has damaged the abductor muscles and is causing a Trendelenburg gait. These patients may even present with a palpable mass or fluid collection near the hip joint, and sometimes they may have clicking or clunking sensation. Lab investigations, first and foremost, you must perform an ESR-CRP to rule out infection. If it's elevated, a hip aspiration is indicated, which can be done USG guided, and often it is a dishwater appearance with a very low viscosity or a watery yellowish gray appearance. Metal ions, you must perform blood tests to detect the serum levels of cobalt and chromium. So usually the cutoff value that indicates metal sensitivity or metallosis is 7 parts per billion. And this is an indication for further imaging of these patients. So in your radiological evaluation, in the X-ray, you must look for any areas of progressive osteolysis, look for component loosening, and evaluate the abduction angle or the inclination angle and the version of the cup. For example, in this X-ray, you can see on the right-hand side, the cup is fairly vertical as compared to the one on the left-hand side. Ultrasound does have certain advantages here. It's cheaper, it's faster to perform, it's not affected by the implant in situ, and it will also allow you to perform a hip aspiration and dynamic imaging. However, ultrasound in evaluation of these patients should be used only when Mars MRI is poorly tolerated or contraindicated or unavailable. So what is this Mars MRI? It is a metal artifact reduction sequence MRI, and it is the most popular of first-line imaging modality for assessing patients with metal-on-metal implants. It allows you good visualization of the pseudotumors and muscle atrophy, and it is a good screening tool even for asymptomatic patients. So again, there are different theories and treatment protocols that have been proposed for metal-on-metal, but a simpler one would be in an asymptomatic patients, you can measure the serum metal ions and look for good component positioning. If these two are intact, you can follow up the patient routinely every year or every 2 years. However, if the X-ray component positioning is poor, and if the serum metal ion levels are more than 7 parts per billion, then that is an indication to perform an ultrasound or Mars MRI. If the metal levels are raised and the X-ray component is poor, and you do recognize a pseudotumor or any collection, then it is an indication either to follow up the patient closely, that is every 6 monthly, or consider a revision total hip replacement. On the other hand, if the patient is symptomatic, again, you detect the metal ion levels and look for component positioning. If the component positioning is good and the metal ions are less than 7, you can have a yearly follow-up. Whereas if the levels are raised or the component positioning on the X-ray is suboptimal, that again is an indication for further radiological evaluation with an ultrasound or Mars MRI, and thereafter you may have to consider revision total hip replacement. So after metal on metal came the advent of polyethylene in total hip arthroplasty. So the term polyethylene refers to plastics formed from the polymerization of ethylene gas. And in 1958, PTFE, that is polytetrafluoroethylene or Teflon, was introduced by Sir John Chanley. And it was used in his initial total hip arthroplasties, but there were two main drawbacks. It had a very high wear rate, almost of 0.5 mm per month. And in addition to this, it produced voluminous masses of amorphous material, which again caused foreign body giant cell reactions. So the debris of this PTFE material caused intense foreign body reaction. And this was even verified by Sir John Chanley, who injected 2 specimens of PTFE into his own thigh and found the reaction to be there. So after the disappointment of PTFE, Sir John Chanley introduced ultra-high molecular weight polyethylene in 1962. So this is basically synthesized from the polymerization of ethylene, forming linear chains, and it is sterilized by radiation in air. So what is the meaning of the term ultra-high molecular weight? So as per ISO standards, it should be more than 1 million grams per moles, whereas as per the ASTM criteria, it should have a molecular weight of more than 3.1 million. So that is by definition, at least 1 million of ultra-high molecular weight polyethylene. Now, what was the drawback of ultra-high molecular weight polyethylene? Was that it was typically sterilized by gamma radiation, and this led to free radical formation. The problem with this free radical formation was it led to oxidation-induced damage and again early wear. So if you look at the pathophysiology of polyethylene-induced osteolysis, for example, in this X-ray here, you can see an area of osteolysis behind the acetabular cup. So what basically was happening was that the wear of the polyethylene would cause wear debris, and these wear debris would then undergo phagocytosis by activated macrophages. These activated macrophages, on the other hand, would release cytokines like interleukin-1, interleukin-6, and tumor necrosis factor alpha, which would in turn activate osteoclasts. Now, once these osteoclasts were activated, it would lead to bone resorption, that is, osteolysis and subsequent aseptic loosening of the implant. So that was the pathophysiology of polyethylene-induced osteolysis. However, this osteolysis due to the conventional poly was attributed to the cement failure, and it was inappropriately known as cement disease. So cement disease is actually a misnomer wherein the osteolysis was thought to be due to the failure of cement and not due to polyethylene, but it was only discovered later on that polyethylene was the culprit and not cement. Then came the advent of highly cross-linked polyethylene, which was introduced in the late 1990s. And the aim of this highly cross-linked poly was to reduce wear and debris-induced osteolysis that we just saw with the conventional poly. And this was done by gamma radiation or electron beam radiation to break the molecular bonds. So it mainly depends on 3 processes, that is cross-linking, heat treatment, and sterilization while avoiding exposure to air. So just a brief note on the processing of highly cross-linked polyethylene. So basically the conventional poly or ultra-high molecular weight polyethylene would undergo gamma radiation. This would in turn break the intramolecular bonds and produce free radicals. The free radicals that would be produced would promote cross-linking across multiple polymer chains and thereby increase the overall density and wear characteristics of the polyethylene. However, the free radicals produced would also cause some oxidative instability, and this required further thermal treatment. There's also vitamin E polyethylene. So what does vitamin E do here? It mainly acts as an antioxidant, and it prevents oxidation of free radicals, which thereby improves the wear resistance of polyethylene. But long-term results are still awaited with regards to vitamin E polyethylene. Now, the main problem here with polyethylene was the correlation of head size and wear. As we all know, that when you use a larger head, in total hips, you're always tempted to use a larger head because you know it's going to give you good stability and reduce dislocations. But the problem with larger heads was increase in the wear. However, with the advent of highly cross-linked polyethylene, they say that wear rates are now going to be independent of the head size. So what are the advantages of a polyethylene liner? So there we come to the practical aspects of polyethylene liners, is that it allows you various offsets, head size options, it allows you elevated liners and also phase changing liners. So what is the meaning of all these terms? So if you see, there are four main types of polyliners in use. First is the neutral liner, second is the elevated lip liner, third is the lateralized liner, and fourth is the phase changing liner. So let us understand the terminology and composition of these polyethylene liners. The first one we use is elevated or lipped polyethylene liners. So you may have a 10 degree, 15 degree or 20 degree lipped liner. So what is the meaning of this lipped liner or elevated liner? Is that there is an elevated rim. As you can see in the clinical photograph here, there is an elevated rim in the polyethylene, and this acts as an extra cover to the liner. The advantage of this is that it provides you an additional few millimeters of clearance and thereby increases the jump distance. So this lip is placed in the region with the greatest risk for dislocation. So if you're doing a posterior approach, you would ideally place this in the posterior-superior segment of the acetabular shell to prevent posterior dislocation. However, one point you should be careful of here is that if you have increased version in your cup, it's better to go in for a neutral liner than go in for an elevated liner, because while this elevated lipped liner will give you some protection against dislocation, it may also cause impingement in a figure of 4 or Faber position. So when the patient may abduct and externally rotate the leg, the neck and the liner may impinge against each other, and it may actually predispose to anterior dislocation. So that is one drawback of these lipped liners. Then you have lateralized liners or the +4 millimeter liners, wherein there is more material on the medial side. So as you can see in the image here, the medial side of the liner is thicker as compared to the edges. And this allows you some lateralization of the center of rotation of the hip by increasing the offset. It also causes some lengthening, but that is negligible. And the main advantage of this lateralized polyethylene liner is it increases the stability by restoring tension on the soft tissues, which can be useful for revision cases or cases of protrusion. Then lastly, you have a phase changing liner. What this phase changing liner does is, you can see in the image here, in yellow is the acetabular shell, and underneath that is the phase changing liner. So what it essentially does is, it reorients your cup in 10 degree or 20 degree anatomical position without really altering the position of the cup. So here you can change the version or inclination of the cup by 10 degrees. That is what is the essential function of a phase changing polyethylene liner. Now, when we are reading about wear and understanding wear, there are various types of wear. There is abrasive wear, adhesive wear, third body wear, fatigue wear, and volumetric or linear wear. Again, I won't go into the details of these types of wear because that's a pretty theoretical topic. But remember, in total knee replacements, abrasive wear predominates, whereas in total hip replacements, it's more of adhesive wear. And here I'd just like to talk about a practical aspect of third body wear. So what is third body wear? These are basically particles which get trapped into the joint space after your total hip replacement. So it may be small bone fragments, it may be some cement debris, or any particulate materials. And this third body wear can lead to catastrophic failure of your bearing surface. And this may even offer an explanation as to why there is some variability in the wear rates and survival in some patients. So the main advantages of ceramic on polyethylene are lower wear rates, no metallosis or trininosis that we saw with metal implants, no adverse local tissue reactions, no ceramic fractures or squeaking that will come to subsequently, and there is now hardly any osteolysis with the highly cross-linked polyethylene. So moving to ceramics, what does ceramic really mean? The word ceramic comes from the Greek word which actually stands for pottery. And in fact, those who do pottery are colloquially called potters, but the real term for them is ceramicists. So ceramic has always been around us, and it's been recently coming in total hip arthroplasty in a more and more frequent manner. So ceramic bearings were introduced in 1970 by Professor Boutin, and his effort was to improve the wear characteristics by decreasing the rates of aseptic loosening that were being seen with polyethylene. Currently, we are using the fourth generation of ceramics. So what are these four generations of ceramics? The first generation of ceramics was made out of pure alumina, and it had a large grain size. That was the main drawback of this ceramic, because this large grain size was actually responsible for high fracture rates. In addition, first generation ceramics had monolithic acetabular components, which were either cemented in directly or fixed in a press fit manner. However, they had suboptimal fixation, which again led to failure of these implants by either causing migration of the implant or tilting of the acetabular component. So the drawback again was high fracture rates. And this was mainly a consequence of the sintering process, which resulted in large grain size. This large grain size caused subsequent ease of crack propagation, leading to ceramic fractures. So in the second generation ceramics, there was an effort to decrease the grain size by adding calcium and magnesium oxide. So these were treated with hot isostatic pressing, and you had modular acetabular components with metal backing. That is, the biological coating improved fixation. So most of these were titanium shells with alumina liners. However, fractures were still a concern with other drawbacks of ceramics, which led to the third generation ceramics, or Biolox Forte, that was introduced in 1990s. And this used a different process of manufacturing, but the main advantage here was it optimized the grain size and increased purity. However, the head fracture rates did go down, but it was still vulnerable to the rim fracture of the liner. So this led to the fourth generation of ceramics, which are in use today, and that is called as Biolox Delta. This is basically an alumina matrix composite, and it's composed of 82% alumina, 17% zirconia, which was added to increase the It contains elements of chromium oxide, which enhances the hardness lost by the addition of zirconia. And this chromium oxide is what gives it the pink color of Biolox Delta. It also has strontium crystals, which form platelets within the alumina composite. And the grain size is now even smaller. That is, it's less than 0.8 microns. The fracture rate with fourth generation Biolox Delta is now less than 0.05 to 0.01%, which is negligible. So what is the main advantage of the fourth generation of ceramics? By adding strontium oxide and chromium oxide, you can see here that it forms a platelet kind of a plug in the microstructure of the ceramic. And this prevents the propagation of a crack. And this concept is similar to rebar in cement. For example, you might have seen on construction sites, you have these stainless steel wires or rebars which add additional support to cement columns, which is similar to what we do in TKR. When we have large defects, we add screws and then pack it with cement. So the screws in that case act as a rebar, which is essentially what the elements of strontium and chromium are doing in 4th generation ceramics. So what are the advantages of ceramics? It has a smoother surface finish and it is harder than metal. There is minimal fretting corrosion and it is more resistant to third body wear. It's biologically inert. So what do I mean by biologically inert? Is that there is hardly any osteolysis produced due to the wear. It's more hydrophilic, it has higher wettability and better lubrication with a lower coefficient of friction. So all these factors give ceramics the lowest wear rate, and it has a linear wear rate which is 4,000 times less than metal on polyethylene, and that is what ensures good long-term survival of this bearing surface. This is why ceramic on ceramic has become an attractive choice for young patients, because traditionally these young patients had poor implant survival as compared to elderly people undergoing total hip replacement. And clinical results of ceramic on ceramic have shown higher survivorship with lesser wear and lower osteolysis. What are the contraindications? So in which patient, if I have a 25-year-old patient and I would like to use a ceramic on ceramic, which are the patients where I will still not use ceramic on ceramic? The contraindications are when you anticipate difficulty in correctly positioning your acetabular component or difficulties in restoring the patient's offset. And you may have some risks linked to soft tissue balancing. These are the main contraindications for young patients where you would want to use ceramic on ceramic. Remember that ceramic on ceramic very poorly tolerates any component malposition. So your cup orientation has to be spot on for ceramic on ceramic. For example, when you have patients with neglected DDH post-Perthes, or as you can see in the X-ray here, a patient with a post-traumatic situation where the patient has had an acetabular fracture or a femoral neck fracture, where there might be weakness of the pelvic muscles and soft tissue laxity, and in some cases of ankylosing spondylitis. So these are the cases where even in a young active patient, you should avoid using ceramic on ceramic. The main advantages again of ceramic is that you can increase the head size, which was seen with polyethylene, where increasing head size was increasing the wear rate. But in the case of ceramic, wear is not directly proportionate to the diameter of the head. So you can select a large diameter head with fewer concerns. And again, registry data has shown that the best survival is with 36 millimeter ceramic heads. Yes, ceramic does have its share of disadvantages, which are increased costs. You don't have the various options of polyethylene liners like lateralized, elevated, or phase-changing liners. And the biggest risk of fracture is with 28 millimeter ceramic heads with a short neck. So what are these disadvantages or complications? You can have squeaking, edge loading, stripe wear, micro separation, and liner or head fractures, which I mentioned, is the highest risk with 28 millimeter heads. So let's consider these complications one by one. Squeaking is basically the noise produced by the articulation of ceramic on ceramic, and risk factors for squeaking are age, obesity, activity level, and malpositioning of the acetabular component. So when you have a patient who's undergone ceramic on ceramic and there is squeaking, there are two broad categories of these patients. Firstly, it may be immediate onset after your total hip, or it may be late onset. So there is a difference in the pathology of these two patients who may present to you with squeaking after ceramic on ceramic. When you have immediate onset ceramic on ceramic, it is mainly because of the separation of the head from the liner. And this is basically due to post-operative soft tissue laxity, which can often be benign and will resolve in a few weeks. However, if it's late onset, You have to look for pain and malpositioning. It may be because of breakage and wear of the ceramic debris. And this late onset squeaking is what will not usually improve after total hip replacement. So this is an example of a patient who had squeaking. So that is what squeaking sounds like. And this is an extremely irritating problem that the patient will even not let go of to undergo a revision. So when you have squeaking, the best option would be to revise it to a ceramic on polyethylene bearing surface. Now you can have liner fractures. As you can see in this situation, the liner can undergo fracture. And this is mainly because of three common pathological reasons. Liner fractures, first of all, are unrelated to trauma, which is the opposite situation of ceramic head fractures. Ceramic head fractures will often be secondary to trauma. Liner fractures, on the other hand, can be because of three main reasons. Either there is malalignment or misalignment during insertion of the liner. That is, there is eccentric or mal-seating of the liner in the acetabular shell, or there is metal back damage of the shell, or lastly, it is because of acetabular component malpositioning, which is causing impingement and edge loading. And the biggest risk factor for acetabular ceramic liner fractures is anteversion more than 25 degrees. So like I mentioned, ceramic liners are extremely sensitive to malpositioning of the acetabular component. There can also be liner chipping during insertion. So here you must remember that when you've put in screws, if your screw head is prominent in your acetabular cup, then that is again a risk factor for liner fractures. So make sure your screw head is fully flush inside the acetabular shell, and use screws only when there is lack of primary stability with ceramic liner bearing surface. So how do you prevent this mal-seating of the liner? Remember, one disadvantage in a ceramic liner is it does not have these pegs or fins, which you can see in polyethylene liners, which allow you easier locking with the shell. So that is why mal-seating liners is a problem with ceramic. So you have this, this is the one which is provided by the debut company, and you have this liner inserting surface or liner inserter, which is basically like a fin. So your ceramic liner can get attached into the fin. You simply plug that around the rim of the acetabular shell and you rotate it once to make sure there is no interpositioning soft tissue. So once you have seated this ceramic liner inserter flush to the rim of your acetabular shell, all you have to do is simply press this central button. And once you press this central button, it will get locked inside the acetabular shell, after which you can have one or two gentle blows of the hammer. So again, this is not easily available. You'll have to ask your implant company, implant guys to provide this. And it's quite a valuable tool to have perfect seating of your ceramic liners. So another practical tip here is that once you've put in the ceramic liner, move your finger around the edge of the liner and the shell. Once you move your finger around the edge of the liner and the shell, make sure there is no step off or no mal-seating. So both these surfaces should be absolutely flush with one another. Again, there are some companies like Smith & Nephew which provide metal backing. What this metal backing essentially does is it provides a titanium sleeve to the rim of the ceramic liner, which allows you easier insertion, protects the taper, and offers high fatigue and burst strength, thereby preventing chipping of the liner during insertion. And it protects the ceramic rim from impingement on movement and also protects the taper of the acetabular shell in case of a liner fracture. Stripe wear is another complication of ceramics, which is basically a long, narrow area of damage resulting from contact between the head and the edge of the liner. This is also a risk factor for squeaking. So what essentially happens is that there is micro separation of the implants during the swing phase. So what happens is that during the swing phase, the hip slightly subluxates, and on the stance phase, this head gets reduced back into the acetabular shell. So if you see in this video over here, in the stance phase, as the femur is moving forward, the femoral head moves outside the acetabular liner. Once it moves outside the acetabular liner, you can see that there is inferior impingement. And on heel strike, once there is heel strike on the surface, this head will again go into the liner, and there is impingement at the superior surface. So I've exaggerated it in this video, but this is what microseparation of ceramic implants can cause problems. So remember, ceramic on ceramic is more sensitive and less forgiving. So it's sensitive to correct positioning. Even though it gives you a very low bearing surface, you must have appropriate component positioning. And as my boss often jokes, that ceramic on ceramic is like your girlfriend. If your positioning is not optimal, your girlfriend will leave you and go. But ceramic on polyethylene, on the other hand, is like your wife. If your wife is upset with you, she'll forgive you after a few days. And in the same way, ceramic on polyethylene is a bit more forgiving as compared to ceramic on ceramic. On the X-ray, you can again differentiate this with a radiolucency. So if you see this radiolucency here, it's a ceramic on polyethylene. Whereas if you don't see the radiolucency, it's probably a ceramic on ceramic. Now we've studied these complications. So the practical points here are, how do you manage these complications? What bearing surface will you choose? And will you retain the stem or revise the stem? So when you diagnose a patient with a fractured ceramic bearing, you must plan a prompt revision and keep the patient non-weight bearing. Why? Because you want to minimize the spread of the ceramic particles in the soft tissues. You want to minimize the risk of abrasive damage to the femoral taper and the acetabular component. You must perform a thorough synovectomy in these cases to remove all residual ceramic particles and prevent the possibility of third body wear. You must have an extensive approach, remove the pseudocapsule and the synovium, and perform extensive irrigation to remove any ceramic particles remaining in the adjacent soft tissue and bearing surfaces. So if you have a head fracture, the points for concern are, will you remove the stem or retain the stem? And what bearing will you go for? So why should you not simply replace the head? Is because there may be mild erosive changes of the taper. You can have fretting and corrosion of the taper, which can lead to a refracture in the ceramic head. So you must look for the stem fixation. Is the stem well fixed? If it is not fixed, you will have to revise the stem. And if it is well fixed, you have to look for the taper of the femoral stem. If there is severe damage to the femur stem taper, then you will have to revise the stem even if it is well fixed. Whereas if there is minimal damage, you can retain the stem and revise only the head with a BioLox option head that I'll talk to you about. Which head to use? You must again avoid metal heads because the ceramic debris can cause catastrophic metallosis if you use a metal head. So that is why in the case of a ceramic head fracture, you have to use a ceramic head. What is this BioLox option head? The BioLox option head is a BioLox Delta femoral head along with a titanium sleeve. So it is this titanium sleeve which will fit onto the taper in the case of you wanting to retain the femoral stem. And on this titanium sleeve, you can put in the ceramic head. So this is the BioLox option head. If you have a liner fracture, the concern is, can you simply exchange the liner or do you have to revise and or retain the acetabular shell? So firstly, evaluate the X-ray in this case. If there is cup malposition, as you can see in the X-ray over here, it is an extremely vertical cup with a high abduction angle. So in this case, you have to revise the cup. If the cup position is good, you have to examine the taper locking of the acetabular shell. If there is no damage and the position is good, you can retain the cup. But if the locking mechanism is damaged, that is, if there is scratching or erosion, you will have to revise the cup. And this is where the protective value of the titanium sleeve on the ceramic rim comes into play. So when you have ceramic fracture revision, ceramic on polyethylene is also a viable option. So the best practice for ceramic fracture revision would be to revise it to a ceramic on ceramic bearing surface to reduce the risk of third body wear. If not possible, then you can consider ceramic on polyethylene, for example, in a complex case or when you need to use a cup cage. And you must definitely avoid metal on polyethylene articulation because of the risk of head erosion resulting in metal toxicity or metallosis. The other question with bearing surfaces is that can you have mix and match of companies? I would say you should definitely avoid this for ceramic on ceramic, whereas for ceramic on polyethylene, you may get away with it, but use the stem and head of the same company and the shell and liner of the same company. Another common mistake made here is that there is interchange between the stem and the femoral head of the same taper. For example, if you see this femoral head and stem on the left side, which belongs to the debut company, both have a 12-14 taper, whereas the stems and the head on the right side are Zimmer, and they also have a 12-14 taper. So can you use a bearing surface head of one company with the stem of another company? Now this should definitely be avoided because the taper angle is different. When you say 12-14, the diameter on top is 12 millimeters and the diameter at the bottom is 14 millimeters. But here you can see one taper in blue and the other in yellow. And as their height changes, the taper angle changes. So that can again predispose to complications of fracture and trininosis. Coming to Auxinium, this is basically patented by Smith & Nephew and it is oxidized zirconium. So it is a metal substrate of a zirconium alloy, which is wherein oxygen is diffused into the metal as it is heated over 500 degrees Celsius in air. So it is a ceramic zirconium oxide outer surface. It is actually a surface transformation of the metal to ceramic or a ceramicized metal surface. So it is not an applied coating, as often it is a misconception, but it is a material transformation. What do we achieve with this is that the strength of metal along with the wear resistance of ceramic. That is the advantage of Auxinium, that it provides the durability of metal along with the wear properties of ceramic. Advantages of Auxinium are, it is surface hardness, it's twice that of cobalt chrome, it avoids the risk of fractures, and another advantage is it is the bearing surface of choice in patients with metal hypersensitivity because of negligible amount of nickel in it. It is low cost and registry data has shown extremely low wear rates. The problem or the practical implication here is of dislocation. So if you have an Auxinium head which has got dislocated, the outer layer can damage and undergo accelerated wear. As you can see in these images, so if you have a dislocation with an Auxinium head, how do you tackle this? If you get an easy close reduction, you can get away with it. But if you have a complicated close reduction, you will have to follow up these patients closely with serial X-rays to look for wear. If there is difficult close reduction, it's better to go in for an open reduction where you can examine the Auxinium head and you may have to be ready with performing an exchange of the head. Lastly, I'll talk to you about dual mobility. Dual mobility was introduced in France in 1974 by Professor Bousquet and the engineer was André Rambert. It's basically, imagine a bipolar head which is articulating with an acetabular shell. So in the image here, you can see there is an inner ceramic head. There is an outer head of polyethylene or a poly insert, which in turn articulates with the acetabular shell. So as you can see here, the head will articulate with the polyethylene And in turn, the polyethylene will articulate with the acetabular shell. So there are 2 points of articulation, which is why it's called as dual mobility. So it combines 2 concepts. The first one is Chanley's low friction principle, where a smaller diameter head will give you a lower torque force and produce lesser wear. Whereas on the other hand, it combines the concept of Mackie-Farrar of using a large diameter femoral head to enhance stability. The indications for using dual mobility would be patients with neuromuscular disease or those who've had prior hip surgery, where it may be a femoral head fracture or neck fracture that was fixed, patients with lumbar spine issues or previously operated lumbar spine, and in revision situations. So why is it advantageous to use dual mobility when you have lumbar spine issues? Is that when you go from the standing to sitting position, it's not only your femur that is flexing 90 degrees. Your femur only flexes about 70 degrees, and the remaining 20 degree is a tilt or a posterior tilt of the acetabulum, of the pelvis. So you can see in the video here, as you are going into flexion, the femoral head is moving in flexion, but the pelvis is also moving behind. So in patients who have a lumbar spine operated, you lose this 20-degree posterior tilt, which predisposes these patients for dislocation, where the real value of dual mobility is there. Another complication here is of intraprosthetic dislocation. So if you see the X-ray here, you might think it's quite innocuous, and the patient may tell you that, okay, there's no problem, and you may send the patient away. But what is this intraprosthetic dislocation? So have a look in this video here. What happens is, when the dual mobility implant has dislocated, so for the sake of demonstration here, I've taken a bipolar head and just put in an old acetabular shell in the pelvis. Now, when you have a dislocation of dual mobility and you are performing a close reduction, as the head impinges on the rim of the acetabulum, what happens is the polyethylene gets dislodged and only the head will go and get seated inside the acetabulum. So this is known as the bottle opener effect. Like you're opening a bottle, the cap of the polyethylene goes out and the head gets lodged again into the shell. Which is why, if you see closely, this is known as the bubble sign. The black arrows here show you that the radiolucent polyethylene is lying outside the hip. And if you look closely at the X-ray, the head or the neck is in an eccentric position. There is more space medially as compared to superolaterally, as demonstrated by the red lines. So this is a unique complication of intraprosthetic dislocation. So again, for dual mobility dislocations, it's better to go in for an open reduction. What are the future trends or possibilities? Are implants like titanium nitride or titanium niobium nitride, diamond-like carbon films, sapphire, or silicon nitride. There is also some research going on for ceramic on metal because they're trying to combine the advantages of ceramic, minimize squeaking and component fracture, and at the same time use the advantage of metal of reduced acetabular wear and reduce the metal debris. However, there's only conflicting data, and this is being used only in a few select centers. Again, compliant bearings are being tried where they're using polyurethanes to mimic human articular cartilage. So what is the perfect bearing surface? The perfect bearing surface is just right now an enigma or an elusive concept because it should have no wear. It should allow you to use a large head with minimal debris which are chemically inert. It should have no fracture, no noise, high resistance to wear with a low coefficient of friction, and it should allow you fluid film lubrication. And this simply makes you marvel at the beauty of human cartilage, which can often last us a lifetime. So what is my algorithm for bearing surfaces? In patients less than 40 to 50 years, I'll go in for ceramic on ceramic. More than 50, I'll go in for ceramic on highly cross-linked polyethylene. For high-risk patients, I'll use dual mobility. And metal heads would be used in selective cases where probably I'm doing a total hip for an elderly neck femur fracture. Thus, to conclude, ultimately, where is the limiting factor in survivorship or longevity of total hips? Long-term studies are yet not available for ceramic on ceramic in comparison to cross-linked polyethylene. And every bearing surface will have its own advantages and disadvantages. But remember, for the patient, your benefits should outweigh the risks. Thank you.
Thanks, Sahil, for an extensive discussion about tribology. So let's see if there are any questions. I could see a few questions in the chat box. One of them is, if the V40 taper has got a lot of failure rate while using with metal head, is there any particular reason for it?
I'm not really aware of any particular reason. Probably Trininosis could be a contributory factor there. But in my practice, I hardly use the V40 taper. So I usually go in for a 12-14 standard taper.
Yeah, so the V40 taper is manufactured, usually it's a striker implant.
Exactly.
And the V40 is just a different type of taper at the angle. Actually, it has not really proven to be failing more as compared to the other tapers. The problem has been, one of the problems with striker ceramic on ceramic has been the alloy that was used in the accolade stem was called as the TMZF alloy. And that alloy actually allowed more squeaking. It functioned like a tuning fork. But the V40 taper as such has not failed more commonly than any other taper. It's been extensively used with both the Exeter stem as well as the accolade stem, and it has done brilliantly. So I don't think that is true, to be honest.
And even
the next question, Sorry.
No, I was just saying that the registry data, even from Exeter and other places, does show good survivorship. So even I'm not aware of any problems with that.
Yeah. The second question is, the highly cross-linked polythene make the material more brittle. What do you think, Sahil? Is the polythene, if it is highly cross-linked, does it become more brittle, you think?
So there are, that is the free radicals that are there do undergo subsequent thermal treatment. So I don't really think it makes it more brittle as such. But then again, that is the whole concept of adding vitamin E as an antioxidant to these polyethylenes. So I don't think that is adding to the brittleness or failure or wear of the liner as such.
Yeah. So Dr. Pachori.
Mahesh, if you go more than 7.5 rad, that poly becomes more brittle. And second important thing is, if it is less than 3 millimeter at the level of the locking mechanism, that there is a tab there, the chances of getting fracture rate is slightly on the higher side. So that is one reason of this highly cross-linked become poly, and the fracture is there. That is the reason.
Yeah. So any more questions?
Up to 7.5 megarad.
Yeah. From the fellows or other consultants, any more questions that you can think of? Anything that you're worried that you haven't understood? So actually, this is quite an exhaustive topic, and everybody needs to understand it.
Yeah, so actually, that's why I try to keep it more practically relevant than going into more of the theory part of it. So I'd like to ask Kulkarni sir and Pachori sir, what is your bearing surface of choice for your patients? How do you decide your algorithm?
One important thing regarding ceramic is, if you are going to have a navigation, you can use this, because the ceramic does not tolerate any of the malalignment. Those people are likely to, in this decade, likely to have a navigation, and then you can use for any patient. You'll be able to use ceramic on ceramic if you have a navigation. Regarding squeaking, you said there was only one company who has the highest rate of squeaking. That was a poor manufacturing. I think too much is talked on squeaking actually, but I think it's not high. The squeaking is two types. One, what you described was benign, and second is malignant. The benign, they've all settled down. Malignant squeaking is the every moment of the hip, there is a squeaking occurs. And these are the people who require a revision regarding this. So that is another important thing. And one important thing of ceramic, why the lower rate is because you can polish the ceramic to highest level. No other metal, no other thing you will be able to do it. So that is one extra advantage of a ceramic, because you can polish this to a very high level. So the wear rate drops down.
Yeah.
And so do you have an age cutoff, sir, for COC, COP? Do you have any age cutoff?
No, but mostly I use for a very younger patients, not in elderly people. Elderly people where I don't want to unnecessarily cost. But by large head, we are almost using mostly ceramic only. Metal head, we are using only elderly population of 75, 80 with fracture neck femur, and the cost sometimes of economics.
Yeah.
But Sahil has covered extremely well, and it's quite interesting for all the postgraduate actually. He has given all possible information, and people can now read and go through, and they can do theoretical part. But he has covered also part of the theory also. He said he will not cover, but he has covered quite a lot.
Yeah. So I think we have covered for this batch. The question of tribology is probably done and dusted now. The recordings, I think, sir, we need to make these recordings available for students.
Yeah, they are.
Yeah. So that they can go back and revisit it, listen to it.
Yeah. Yes.
Are they on the ISHKS website?
Yes.
Okay. So anybody who wants to revisit any topics can go actually on the
plus a lot of other things are there on our website. Previous last 7 to 8 years lectures, meetings, they are also trying to upgrade them. All the members, we have provided them the password and everything, and they can go through that. A lot of things are happening, Mahesh.
Yeah. And the students, they also want to join the ISHKS platform. Is there any special rate for them, or is it the same rate?
No, it's the same rate. Mahesh, they are getting more stipend than you and me.
Okay.
No, this is online, and it is very easy. Within just 5 minutes, they'll be able to log in and on online, and they can they can get the membership. So I request all of them they should join ISHK as a member. It is very easy to do it. Just on our website ishk.com. Just go to the membership form and open, and just require 4 things. One is a passport size photograph. One is your degree certificate. Second is their medical council, and lastly, a very short CV. And they can put any doctor's name as a referee. Those, if you know them, fine. Or they can put Mahesh or Sahil or anybody. So they will get an email immediately. And once we approve, then within 24 hours, they will be able to be a member.
Okay. What I was thinking is the dislocation talk. It's a very small one, but I would like to combine it with the treatment for dislocating hip as well. So today it may not be appropriate actually to press on with that small talk without actually covering the treatment for dislocation. So maybe we can reorganize that, where I will talk about prevention of dislocation, and I will get somebody else to talk about how do you treat a patient who is dislocating repeatedly. And I think Dr. Dhanashekhar Raja is going to organize the next session. So I'm going to request him to probably have some knee topics now, because we have dealt with hip topics for 2 weeks in succession.
Yeah, alternate. I think we should do hip and knee both.
Yeah.
That is much
so next time you have covered the evolution of hip replacement. Dr. Deepak Dave is ready to cover evolution of knee implants. So I think one of the talks will be evolution of knee implants, and then I'll request someone to cover maybe alignment in knee replacement. I don't think we have done it for this batch. So I think we should then conclude this session, Dr. Pachore.
Yeah, fine. Fine.
And then thank you very much, Sahil, for an exhaustive discussion. And it was very interesting, and it actually covered everything that a fellow or a student should know. So thank you for your time, and we will hope to see you again. And thanks, Dr. Pachore and the organizers, Hallmark Events. And we will see you again in a couple of weeks' time. Thank you.
Thank you.
Thank you, Kulkarni sir. Thank you, Pachore sir.
Thanks.